Yeah, hi everybody. Uh, I'm doing these are supplemental lectures. Um, we do not have class on Friday as everybody's off. It's Good Friday, and basically we're beginning to run out of the amount of time that we need to cover all the physiology and get the presentations in. So I'll be explaining on if you're listening to this before we have class tomorrow on Monday the 30th, what we're going to do about that. But I did want to try to finish up. We have a minimal amount of immune. I've forgotten those last couple of slides I wanted to go over, and I want to continue with the circulatory physiology. And then at that point, I will basically dedicate Monday to respiratory physiology. And so, with all that in mind, let's begin. So I'll show you where we left off as I scroll over here. And this is basically the area. You might remember we were doing these hypersensitivities. And And I think again, I suggest this is when we were talking about the typical immediate hypersensitivity, allergies, and even hives, typical response to colds and things like that. That all the things that you can see are demonstrated. And again, to remember that anaphylactic shock, the most severe of all of these, it's going the wrong way. And so again, when we flip back, but that's really when it affects those respiratory ones, asthma and anaphylactic shock, the most severe, but they can happen immediately. And I remind you that there's an initial exposure, that next exposure can lead to that kind of tragic. I'm trying to get a comfortable spot here while I'm talking. That kind of tragic complication. There's really only three other true categories. Two in this hypersensitivity, okay, subacute and what we call type 2 reactions. And then lastly, you'll begin to see it. So really, we're not going to classify it. Subacute means really that maybe that's a better way to explain. Just let go with the description of the PowerPoints. You can see one of three types, the way they classify it now. These are mediated by both IgM and IgG, and typically these are associated with transfusion reactions. They take more time. Again, it's not that initial because of the mast cell. It's a little bit different, and it lasts for a longer period of time, and that's significant. And what happens, these are antibody mediated. These are the two major categories of antibodies. So when someone's getting a transfusion, okay, this potentially can happen because the antibodies are already in the system and all of the things that occur because of it. So mismatched blood transfusion is the classic example. They bind to those antigens, they stimulate phagocytosis, etc. All of the events that happen. And so anecdotally, when I had those transfusions, this was the typical instruction as they gave you. I mean, of course, they're monitoring you during the transfusion. Well, a transfusion would take a couple of units of blood, might take, 2 to 3 hours potentially, something like that. Not a terribly long amount. And assuming they're not trying to push it in fast, believe me, in that type of a thing. So they would send you home and basically say, take your temperature. The first sign of that reaction would be an increase in temperature. And then you're starting to, and if that starts to increase or any type of feeling that is very unfamiliar, you're to get in touch with them. And believe me, go back right away. They are ready for you. There's no trouble being seen on that because you're basically seeing an outpatient unit that does the transfusions. Generally, they treat cancer patients that are there. That's the case at UPMC. And you go from there because they got to get cracking on that. You might have to be on dialysis. And really, what happens, let me go backwards. Really, what happens, you may remember me saying it, when you start to, those clumps are very hard to get rid of. They clog the kidneys. And if you don't get working on that right away and basically cleanse a lot of those properties out with the utilization of something like dialysis, big trouble coming your way. I mean, you could permanently damage a kidney. Moving on. This is the second sort of subset of those. And these are immune complexes. Same idea, basically. In transfusions is particularly kidney oriented. And this is what happens, and basically this is a typical autoimmune phenomena. These insoluble antigen and antibody complexes, and they can't be cleared, and all sorts of problems associated, very inflammatory. Diabetes would fall into this category. Okay, they're giving the classic example is certainly systemic lupus erythematosus, which is it's a different kind of, but these complexes basically they target specific organs. Systemic lupus is just that, it occurs systemically. So it hits the classic autoimmune disease. We may have a presentation on that. It targets a variety of different things. Kidneys are certainly it's the second most common cause of having to go on dialysis or having a kidney transplant after diabetes. That's why diabetes is in this category now of autoimmune diseases, because these protein laden complexes form in the kidney itself and basically lead to high blood pressure. And eventually the kidneys just can't function anymore. And at that point, the only alternative other is dialysis and or kidney transplantation. So that's one example of where the diabetes, but the lupus, every organ is at risk. That's why it's so, we call it systemic. It's so widespread. Uh, Again, in addition to rheumatoid arthritis, these are really the first two autoimmune diseases. If it's an area of interest, then you read more about it. Uh, there'll be a lot of articles. I'm sure there's some wonderful YouTube presentations or podcasts about it that you can access if that's of interest to you. And then the classic delayed hypersensitivity. These last ones that we've described are all cellular. Our bigger part are all humoral. In other words, are about antibodies floating around, either antibodies that are released or antibodies that are brought into the system. They create the problems. Whereas here, this is delayed reaction hypersensitivity. This is about cellular immunity, and it's all about helper T cells. Okay, and what happens is, as long as the helper T cells get so activated, they activate macrophages and they activate cytotoxic T cells. And typically, we see this because the agent acts in an odd way, but on the cell rather than on mast cells, and creates effectively a cellular based response that acts almost like a hapten would in an allergy. And this is so effectively when you get a TB test, it's called PPD or purified protein derivative. It's designed to mimic that effect. So it acts almost as a hapten like substance that will cause that reaction. And as we all know, it's typically if it responds immediately, it's really being an allergy. That's why an immediate response means, oh, you're just allergic to that particular agent that they're using in that attempt, that diagnostic test. Where if it takes 2 to 3 days to really show up and meets the appropriate criteria, that's a positive test. Doesn't necessarily mean you have tuberculosis, but does mean it's a positive test. And certainly, I saw a ton of contact dermatitis. Depends what you often see. Sandals are maybe the biggest culprit, and things in the way shoes are made. And nowadays, things are people wearing a ton of tennis shoes or sneakers or basically sport type shoes, which are made from a lot of synthetics. Don't have the problem. But in the old days, and sandals particularly had leather uppers, and the leathers are made with chemicals used called resins to impart certain textures and certain colors. And when they meet with moisture, when you're perspiring, which you do when you walk, okay, or gets irritated for any reason, boom, they get absorbed in the skin, and you get a classic what we call contact derm. And it's not just shoes; it's anything can give it to you. And of which we saw a lot of, and usually the treatment for that was typically a steroid dose pack and topical steroids, which work very effectively if you caught them at the right time before they got a bacterial infection. Thus ends the saga. Those guys. So we're done with that. So I had forgotten to do that, and I apologize. I was so interested in starting blood vessels, so I'm going to continue with that as I X this out. Oops, I just Xed it all out. Oh, that was a boo boo. But Never let it be said, we will not continue and do this. Hold on. Here. That'll come and I'll get it in a second. Don't worry. That's the micro PowerPoint that I use. Here we go. So I got to get chapter 18B. Oops. And chapter 18C. Oops. So C's over there. We'll get ourselves over to B. Just a second. There we are. I get busy and scroll down. We did all this pressure stuff. And we basically ended when we were looking at, you might recall some of these slides as I scroll through, and all the different things. We got to the baroreceptors and the chemoreceptors. So remember, and this is just to reiterate, the baroreceptors are pressure changes. They solve the problem by either increasing or decreasing heart rate, increasing or basically leaving force of contraction alone. Okay, those are basically the way that the adjustments are made by the baro or pressure receptors. And we talked about, with regard to orthostatic hypotension, meaning that there's those pressure sensors don't work, and the whole idea of why your blood pressure drops. I mean, think of it. You're just gravity 101. But those sensors are really designed to prevent that. So when you make sudden positional changes, and it's something that weakens with age, just to reinforce it, because it's really important, and it's something that weakens with certain kinds of medication. And if you're going into a clinical field, if it's you, if it's your mom and dad, if it's anybody in your orbit, I mean, I just trying to, they're just going with that stupid teeter-totter thing. These are really significant because a lot of you get dizzy and fall with an older person, something bad can happen. Okay. You see it all the time. It's so critical. I mean, people. My mom lived to be 93, and I mean, she was pretty functional until she was 86 and driving. But she was very careful getting in and out of the bed, going to the bathroom. She had one of those, the kind of apartments where you just have that walk-in shower where it doesn't have a step or anything like that. All of that is really significant. All those little factors help, particularly. I did a lot of geriatric medicine, so I'm very familiar with it. The chemicals, again, and the take home point are the big player. And we see this reinforced again and again is carbon dioxide. Carbon dioxide, as you will learn when we get into respiratory, is not something that's easily dealt with in the sense that carbon dioxide and its effect on pH plays a much more pivotal role in your brain than you would think. And it's because of the absence of what we saw in the blood, that very important thing when we review again and again, the carbonic acid buffer, which is carbonic anhydrase. That enzyme in the bloodstream facilitates that change from carbonic acid back to water and carbon dioxide. That's going to be the big player why carbon dioxide is such an important, is really the key agent in forcing us to breathe because we can't deal with it in the central nervous system. So these chemoreceptors, this is the big player. And what happens as carbon dioxide rise, pH begins to drop because it effectively makes more carbonic acid. Back to that buffer, which is so critical. And then oxygen takes a hit as well. But if you have to rely on oxygen sensors, you're already in trouble. And so, really, what they do increase blood pressure by basically the cardio to increase cardiac output and vasomotors to increase constriction. So, I mean, here, this suggestion, we're looking at dropping blood pressure being the underlying feeling, and then we'll deal with it from a respiratory. So, there's a lot of influence. The centers are in the medulla, hypothalamic area, certain times during stress, exercise, redistribution of blood. These are the centers that are involved as we look at how blood distributes, and we'll get to some of that relatively shortly. This, to me, is really the critical piece from a standpoint of what you will probably see on an exam. It's more about this kind of stuff. because we look at hormonal regulation. We visited it a couple of times, so it doesn't hurt to visit it again. So hormones regulate blood pressure in short term via changes in peripheral resistance, but longer term mechanisms, changes in blood volume. So there's a couple of these that play a role. We've discussed them before, so you should be familiar with them. Again, from the adrenal medulla, this is all about the sympathetic nervous system, cardiac output, and vasoconstriction when needed. Okay. So blood pressure is getting lowered, epinephrine and norepinephrine from the adrenal medulla. Angiotensin 2, again, that's a mechanism. You remember, we'll look at that kidney mechanism again, that renin-angiotensin-aldosterone mechanism. Antidiuretic hormone, which is triggered by angiotensin 2 when it's activated, and by other mechanisms, just general thirst, just sensors there anytime because we know we're thirsty. And atrial, the opposite, that sort of anti-aldosterone, that ANP, atrial natriuretic peptide. And because it stretches the atria, they release that chemical directly into the bloodstream, and it basically gets rapidly to the kidney and begins to push more sodium out, and again the water will follow. And so review those. The classic long-term mechanisms are renal. So the baroreceptors can adapt, okay, over time. So they're short, they're not something that's going to make long-term adjustments. So the longer-term mechanisms are really based in the kidney more than anything else, and they're classified as direct and indirect. So if you're looking at direct, and we haven't gotten to the kidney, obviously, but direct mechanisms play a role, okay, independently of hormones. They play a role, if you recall back to our anatomy, at the glomerular level for the vast majority of times. And what they do is, it's stretch receptors. It basically is trying to control the amount of flow. If the kidneys rely on high blood pressure, they're a high pressure filter. If the pressure is too low, they have to squeeze tighter to increase the pressure. If the pressure is too high, they'll do the opposite. They'll lower it down. And so, and it's all function. The more pressure and the more volume that goes through the kidneys, the more you will urinate. And that gets rid of water and it reduces blood pressure. So when it's high, we push more fluid through the kidneys. When it's low, we restrain that. We want to conserve water. And there's ways that you can shunt it around. And I don't want to go through all the things that are here, but the direct mechanism just has to be adaptation. This indirect is that very famous renin-angiotensin-aldosterone mechanism. You remember the juxtaglomerular cells, the mesangial cells, the granular cells, all of those effectively are releasing renin. When there's a decrease in pressure, it activates an inactive protein that's made by your liver, that's in your bloodstream all the time, called angiotensinogen. It activates the angiotensin 1, which has limited effects, but will start to tighten the blood vessels. And then is converted additionally by what's called ACE, angiotensin converting enzyme, in the lung to angiotensin 2, a very potent vasoconstrictor. Its first job, it vasoconstricts, and it acts on the hypothalamus directly to increase thirst, retain more water, you're thirsty. It works on the posterior pituitary to release antidiuretic hormone that basically retains water from the filtrate and pulls it back in before it goes into the collecting ducts. And then lastly, in the adrenal cortex, and perhaps as important as any, it induces that most external layer you might remember of those three, the fasciculata, the glomerulosa, and all that type of stuff, the reticularis. Okay, so it secretes aldosterone, and that works directly by inserting basically tiny protein passageways in that collecting duct and distal convoluted tubule area, and they pull back sodium, water follows, and voila, up goes the blood pressure. So the indirect mechanism, again, renin-angiotensin, the mechanism I have just described for you in detail, I don't need to go over again. You should know, and you must know, the 4 ways that it works. The time's come. We touched on an endocrine. We'll revisit it undoubtedly in kidney, but this is so pivotal to understand what an important mechanism. It's just a must for understanding basically blood pressure, renal physiology. Here's the aldosterone, because really this is the big control, not just for water but for sodium. I mean, we have to be. You're not concerned because we have a wide range of sodium, but sodium is such a big player. When sodium is really this enormous player when it comes to fluid balances and things like that, and that impacts all other systems. So, antidiuretic hormone, thirst, potent vasoconstrictor, directly increasing blood pressure. And if so, you seeing here we go, seeing it again, and the whole idea. And this is the term I wrote on the board: perfusion. Perfusion means the organs are getting enough blood supply to work. If they don't work, they don't have enough blood supply, they don't work, or they don't work effectively. And that is an extraordinarily slippery slope. It's very hard unless you've encountered it in your lives, maybe not personally, but as a family or with people in your orbit, to know when things start to go bad, they go bad. We call it multi-system failure. This is one of the things that starts doing it. So blood pressure, whether it's too high or excessively low, effectively, if it's not well controlled, if you're not getting blood supply to organs, the organs begin to deteriorate. If nothing else, we should have learned in this course, all of these organs are interconnected. And if one's messing up, the others have to compensate. Then they start to mess up, and more have to compensate, and eventually can't compensate. And then usually that becomes terminal. So, examples. If it's too low, you might think you faint, lose consciousness. There's nothing unusual about that. A lot of times it's just, faints at the side of blood, or faints at the side of the needle, like my daughter. And if the brain is too high, the pressure could cause a blood vessel to burst. It's not rocket science, but it gives you an idea. And it's just, to me, it's just an important take home point. But however you use this course going forward, whatever it means to you in the future, these are important things, I think. And again, you can look at all of these things that influence your blood pressure. And so now we begin to look at things that impact it. Okay. And there's so many things. I mean, if you're upset, your pressure goes up. If you have a fever, your pressure goes up. If you're working out, pressure goes up. The postural changes. And all of these play a role. In general, as you're older, your pressure goes up. Men generally have higher blood pressure than women, has been my experience. If you're overweight, they grow up. Generically speaking, I don't like to paint with a broad brush, but what we were taught years ago is that people of color generally were ones who typically had hidden high blood pressure. And believe me, that is real. That really, the understanding of what we called essential hypertension, that really didn't have, and we used to see that in folks of color, was really, because then all of a sudden you'd have a tragic accident happen and somebody who was in their 30s or in their 40s who didn't know about it. And certainly it affects your mood, but we don't know about it. You start with headaches, and it's like, and the posture we talked about. So the definition of that is high blood pressure, and whatever the modern criteria is. Like I said, this PowerPoint is about 8 years old, but 140/90 has been around forever. Sustained. Sustained means, oh my God, I went to the doctor and my blood pressure, he checks it's 142/91. Oh my God, I'm going to die. No. Just like any test, it's a snapshot. You have to test those things. And typically what a doctor's office will do, they'll have you, if you could check it at home. I'd rather have my staff check it. Come in, stop by anytime in the morning, twice a week. We'll check it. That's all. Try to make it around the same time or times of day We're here from 9 to 12. 12 is usually lunch. Someone's always around. It's not hard to check your blood pressure. Then we can actually see what it is that are there. And so it's the kind of thing, and you start to get a pattern. And then you begin to, and you investigate all the other factors we'll get to. And again, there's lots of things that can play a role with it. And again, every people, my pressure was way up too back in the day. I had a diastolic, it was over 100, and I was 20 years old. And I'll tell you the same story I tell everybody else. Our whole family died. Okay. My mom didn't like it, but my dad and I thought it was great. And I'm going in there. I forget what I was going. I think I had some gut problems or something like that. And he goes, check my blood sugar. He looks at me and goes, look, I weigh 260 or 270 pounds. He goes, when do you want me to book in for your stroke? Just like I'm saying, Lou, you're going to have a stroke if you don't stop what the fuck you're doing. Smoking, eating, dumb stuff. Right? Hard lesson. So these are the types of things. Hard, because it's the pressure on the system is immense. Your kidneys, they need high pressure. They don't need high blood pressure. It's a high pressure filter, not an excessive pressure filter. Just take your coffee filter and go from drip and hold on to it and just turn the faucet on high. Boom, it's going to tear. All of those kinds of things are like it. And then the big problem is your heart has to work harder to open those blood vessels, that diastolic, that resting tension. The heart enlarges. At that point, it's overly muscular. It can't contract as efficiently. And then the reverse happens. It doesn't circulate well, there's not enough blood, and those overactive muscles begin to effectively die. Okay? And there's all of those factors. We call it primary hypertension. That's the primary or essential hypertension. You really don't have a particular cause. All of these things: heredity, diet, obesity, age, other medical factors like diabetes, stress, smoking. Those are all things that are certainly, you can try to reduce the stress in your life. You can treat diabetes. You can't alter heredity, but if you know those things, you can work on it. But all of those things, common sense, nothing here you haven't heard before. The beauty of high blood pressure medicines is they have minimal side effects, typically. Long term, they can be, because there are problems associated with persistently lower blood pressure as you get older, like the orthostatic hypertension. Okay. Interestingly enough, that's where they really, when you hear about ED medications, erectile dysfunction medications, that was one of the early problems we saw with a couple of categories of medicine. We saw them with those SSRIs, those for mild depression and eating disorders, and mild, a variety of different agents that were used, mood disorders, panic disorders, those kinds of things, but particularly with early blood pressure medication. So people began to see certain kinds of dysfunctions in that regard, and the industry started looking at those, basically how they work. When we look at repro, but how agents of that type began to work on the nitric oxide system. Moreover, these are things you can deal with. I deal with them all the times and not so all the times. You can't deal with age very easily and heredity, but everything else you can kind of handle. And those kinds of things. So you have to be very, very watchful of those types of things. And really, it's my trouble is I love to eat. I love to eat the wrong things, But we all know the ways that you can deal with it: exercise, stop smoking, trying to lose weight, or even losing any weight. Just doing any of those, it all works to it. And as I look at you guys, I'm not seeing people that you're young and healthy as far as I can tell. Here's what we see: less common due to some other disease entity. Diabetes is more syndrome type, so we're not necessarily. I understand it might be one of those, but that's more treatable than as we begin to look at some of these. I wouldn't use the word exotic, let's say less common, but these are very much disease oriented. So controlling the disease will control with regard to secondary hypertension. Not too big of a deal. Okay. My wife consistently is like 110/60. For a gal who's, the wrong side of the 60s, let's say, without revealing too much. Okay. She never smoked a day in her life. We don't drink at all. Over the massive part of her life, her weight's been very, very well controlled. My sister would fall into that, but her weight's even better controlled because I'm gaining weight. And here's the orthostatic hypotension, chronic. I mean, these are other things that are dealable. Acute, important sign of circulatory shock. It's when someone's never had it, and you'll know the difference. Now, circulatory shock would be typically internal bleeding or external bleeding. An annoying cat who's making his presence felt, but he's not going to be able to do anything about it. We're almost done with this part. So these are the different kinds of shock that are there. I will try to address his needs. You are fine, sir. Hold on. No, we're not going out. Put the dog out. So you're going to have to stay in here for a while until the dog goes out for you. Okay? That's fine. You're good. Sorry about that. So when we're starting to look at these types, let me back up one more. The acute hypotensions are a little bit different. I mean, you can identify long terms and short term ones, but circulatory shock, okay, there's a lot of things that can cause that without going crazy about it. That's when someone becomes septic. That can be part of it, for instance. That's there. And certainly internal or external bleeding. And, hypovolemic is very specific as to large scale blood. And again, in my case, it was chronic. And then I was losing it internally, basically into the gut. And, it was, and so I was basically excreting it. I mean, it was awful that were there. So when we talk about shock, basically it's inadequate perfusion of vital organs, and pretty much starting with the kidneys would be the first one that really are effective. And then of course you're not getting enough to heart, you're not getting enough to the brain. All of those things potentially will lead to will kill you, undoubtedly. So it's hypovolemic, lack of blood or loss of fluid, circulatory, because the blood vessels can't fill, and there's so many underlying things. Okay, extreme vasodilation. I mean, that's when you're talking about anaphylactic shock. All that release of histamine has dilated those blood vessels. There's no resistance. Inefficient heart, cardiogenic shock. That before the advent of those AED machines that we're so fortunate to have, and I do have to finish the cardiac unit with you. Those AED machines. It is cardiogenic, typically 5 to 15%, even with, I'll reiterate this again, 5 to 15% of all attempts at defibrillation were unsuccessful. Okay. And that was cardiogenic shock. But when we defibrillated, it reduced it significantly. The fact that you're pushing on it isn't going to necessarily restore it back to its normal area. So that concludes that particular part of the PowerPoint, and we're doing okay. And again, here, this really just deals sort of limitedly with the idea of perfusion, delivering of oxygen and nutrients, removing waste in cells, gas exchange, absorbing urine formation. And I mean, all of these things need to ensure perfusion, and all the things we've discussed in this presentation about making sure it gets there. And so there's different controls. that we had spoken of, please, the sympathetic nervous system, hormones, acting on the arterioles. Remember, that's really where all of this is controlled, that are there. And then local flows. So in this, even locally, local release of waste products will alter the arterioles themselves, modifying their diameter so the organs regulate their own flow without getting into too much detail. So we have a variety of different things. They give you some page things and all of this stuff. And so really here's by and large blood pressure, things like this is very well auto-regulated. If it is not, then there's really underlying problems that have to be addressed with a lot of those factors. This is the great thing. At rest, your muscles, my muscles, sitting in class, 20%. During exercise, up to 70%. We can increase it 3.5 times. And we've talked about that in fight or flight. Skeletal muscles dilate. At the same time, we have more blood flow to the heart. We restrict the blood flow, as you will see from other areas. And so extrinsic controls decrease the blood flow to other organs, such as the GI and GU system, gastrointestinal, genitourinary system. And we maintain this, but we maintain the arterial pressure despite dilation of the skeletal muscle arterioles. It's a great slide. Look what happens. So we're going to increase this by a factor effectively of 3 during vigorous exercise, let's say. The brain gets the same. You don't get 3 times to your brain because you're thinking hard. Your heart triples. Your skeletal muscles increase by a factor of 10. So where did all this go? Well, your skin has to dissipate heat. That increased 3 times. But look, your kidneys, rather than going to 3,300 and 4,200, get not, they don't just diminish proportionally, they diminish dramatically. So if this is 3,300, this is 1/6, 1/5, 1/5.5. Same deal here. This is 1/7. Okay, and odds and ends going to other places aren't that terribly significant. That's the big thing. But it's GI and GU, gastrointestinal, renal, and this is really the genital reproductive area, etc. And so, and again, different things happen. Reactive hyperemia, when you block something off, it's like when you put a tourniquet on and to work on an extremity, whether it's an arm or a leg, and we do it all the time. We're doing a knee procedure because it's a whole lot easier to see without blood flowing everywhere. What happens? It builds up a pressure head, and we'll talk about that pressure head when we talk about reproductive physiology in the female and menstruation. And you get a phenomenon called reactive hyperemia. That's a pressure head. Is when it's released, the pressure comes through. Okay. And they're looking at these different kinds of control. I don't go crazy about metabolic or myogenic. Metabolic. So what happens? You're ending up with less oxygen and you end up with more waste products. Just very, very simply. Okay. And those change local chemicals. Okay. So, and that's what I was talking about before. What directly relaxes those local chemicals, waste products like acidity and potassium, even adenosine, which tends to dilate because it's more of a relaxant, and prostaglandins, local mediators, and they cause the release, as you can see, of nitric oxide, which really is the vasodilator to make sure there's blood flow. Other things, endothelin, are potent vasoconstrictors. So they usually balance unless blood flow is inadequate. In that case, nitric oxide wins. So these are 2 things that are released from the lining cells in your blood vessels. And of course, inflammation plays a role. Sorry. Myogenic. Local smooth muscles responding to changes in the arterial pressure. You can read through that. Long term. Okay. And this is what happens and this is the benefits of exercise, the benefits of utilization. Long term, we build more blood vessels. That's the beauty of our body. When we're using something more, our bodies acknowledge that and create angioneogenesis or neoangiogenesis. So they're building more blood vessels. These are peripheral. This is the heart thing. This is the high altitude thing. This is why I'm working on the treadmill. This is why you do your cardio. You build up more channels that are there. It's very much use it or lose it. And if you use it appropriately and keep it open, it's to your benefit. Now, you can look at that for summary. And this is just showing the different types that are there. We know that skeletal muscles can increase even by a factor of 10. And it's just showing some of the things that go on. The brain remains constant. And again, increased CO2, which basically makes decreased pH very significant. That's why that carbon dioxide, we're going to get to that more in respiratory. All the different things that the brain controls that are there. And again, these are localized myogenic controls. But if your MAP falls below 60, then you can faint easily. And if it above 160, big trouble. Your kidneys work in a slightly different range, as you will see. But typically, the map for kidneys is about 80. Unless somebody's adapted to, have, relatively, like my wife would have had, where you're dealing with maybe her average map was slightly below 80. It's not a big deal because it's been that way for her lifetime. As you can see, the problem, and syncope is an important word that means fainting. And the skin, obviously, we know all the things it does, temperature, even about 5, maybe as much as 10% of your blood can be in there. And so it can vary to dissipate, basically dissipating heat would be the best way to describe it. All of those things are there. To me, this is read around. And so you see as temperature decreases, the super skin vessels constrict. And this is why, if you're interested, why, oh, you're out in cold so long, it's almost an optical illusion. The vast majority of the blood has gone in, but it means that something's trapped in there. And the lungs, we've done enough of, and we'll look at the pressures. Okay. And everything will be opposite because it's a special circulation. The heart, you can read through that just as easily. So, as you can see, when the heart's contracted and the coronary vessels don't get any blood, we're going to do the heart tomorrow. If you're listening to this today, we're going to do the heart on the 30th. And really spend a day with the heart, looking at it, and then moving into respiratory. Myocardial blood flow ceases. Stored myoglobin supplies sufficient oxygen are there, thankfully, that will hold on to that's in between, so the oxygen is maintained. And during diastole, then the pressure takes care of the circulation. As you can see here, they use a proportion of this. I'm buzzing through these because I don't ask a lot. Let's see. There's a little bit nugget here, but I'll come back and I'll finish this. I'll just make another brief presentation to finish it so I can give my voice a rest. I'm sure you're tired of hearing it. Thank you very much. All good. Stopping the recording.